Welcome to Beyond Weight, addressing weight-centered issues in obesity. Hello, I'm Dr. Robert Kushner. I'm a professor of medicine and medical education at Northwestern University Feinberg School of Medicine in Chicago, Illinois. And today I'm joined by Leigh Perreault, who's an associate professor of medicine in the Division of Endocrinology, Metabolism, and Diabetes at University of Colorado in Aurora, Colorado. Welcome, Leigh.
Thanks so much, Bob. Pleasure to be here.
Leigh, I'm really looking forward to our conversation about addressing patient-centered care in the clinic. And I want to start off with perceived barriers. I think that makes the most sense for primary care. There's been actually a lot of studies published on this topic, and barriers that have been identified include addressing competing priorities, time limitations in a busy clinic, lack of resources and referral pathways, and low confidence due to insufficient training, among many others. What do you find to be the most significant barriers to effective management of patients with obesity in clinical practice?
Yeah, it's a great question. And I actually moved my practice out of our main campus and into a community clinic that's part of our healthcare system. So I've actually been practicing in a family medicine clinic for the last 15 years. So I get to see these barriers in action. And I would say there's basically three general categories that the barriers fall into, and they all generally stem from the same place. And that is that obesity has really been perceived as a lifestyle issue for so long. So the barriers on the side of the patients, they feel like it's sort of their fault. They've never been offered care in a medical setting. The providers, they feel like it's also sort of a lifestyle issue. And so they have been trained to tell the person to eat less, exercise more, and then they will refer them out to a commercial weight loss program. And those programs, they work for a certain amount of time until the person no longer can afford to go to that program anymore, or they don't feel like it's as effective enough for them anymore. And then the third sort of general barrier, I would say, is the insurers. So the insurers also have thought that this is sort of a lifestyle issue. And so they haven't kind of gotten up to speed that this is actually a serious medical disease. And this is something that we do need to be taking care of. So, the patients are sort of left without coverage for any care. And then the providers, of course, can't provide any care that's not covered. And so it's really sort of those three general things that we still have yet to take obesity seriously as the chronic, progressive, serious disease that it is.
Sounds daunting, Leigh, but I know you have tackled it head on and you have developed a program at UC Health called Pathway. I've heard you talk about it at different meetings that I think is designed to integrate obesity management in primary care. And I presume you've taken many of these barriers into consideration when you developed this. I wonder if you could kind of briefly tell us, what is the Pathway program?
Okay, so the first thing I want to make very clear is it's not a program. It's not fee for service. It's not standardized. It's not duration limited. It's not none of those things. Pathway is the highway for everything in obesity care that is now and everything that is to come to drive on. So it is a care process. It is a way for patients to get care. So it activates patients and allows them to know they can receive medical assistance with their weight if they would like to. It also empowers and educates providers on how to conduct care for weight. So we sort of say Pathway with a WEIGH is a two-way street because patients are empowered and activated, and also the providers are educated and they're resourced to do it. So it is not a weight loss program. It's intended to be enduring medical care for weight management that lives in primary care. Like I said, I worked in primary care for more than 15 years. I see what those barriers are. And so really Pathway is designed to address all the many barriers of letting patients know they can receive care, helping them schedule a specific visit around that, making that visit extremely time efficient, having our electronic medical record really do the brunt of the work in terms of being a real asset and a resource for our providers instead of a stumbling block and a place that all they do is just type instead of actually talking to the patient, and a way of reminding providers what all of the different treatments available to patients are now, because we are in a time where the options for patients are not only so much better, but the numbers of options are exploding. And so I think a lot of providers just they don't know. So it's really just putting all that information in front of them on our electronic medical record. So it's all about making weight management easier to do than to not do.
Mhm. So it sounds like you've put a lot of these resources, right? So it's a typical flow of a patient visit. Do you recommend a weight-centric visit versus building it in the last 5 minutes of a primary care visit?
100% yes. I mean, because primary care, they're dealing with 14 different things in 15 minutes. I mean, weight management, it's a big thing. You're addressing all that has come before in that patient's history. And that's frequently a lot. And that conversation can be very emotionally charged, and it can be full of information that is highly relevant to what that individualized treatment plan is. And you need time to hear it. And you need time to educate the patients about their options and to remind them that life is a journey and that there's speed bumps along the road, and we're going to hit speed bumps and we're going to get over them and continue down the road, and that road is for life. It's not just, for the next 3 months. I tell my patients, I'm with you for life. And they always kind of giggle. And then I say, no, I'm actually serious. We're together for life. So yeah, I think you definitely need a weight-focused visit.
What are the most important points that a clinician should tell a patient? What should a patient know about obesity? Like a journey you just said, I'm there for you. But are there other key points that primary care clinician should be talking with the patient about, either at that first visit or somewhere along the way?
Yeah, I mean, I think the first most important thing is that we listen. The patient's going to give us little bits of information that are going to be really relevant to our treatment plan. As an example, that patient's sitting there telling us that they're having a lot of family stress, and that is really impeding their ability to engage in healthy lifestyle behaviors. And so that's somebody that if you're listening, you might think, wow, this patient might really be supported by help with our behavioral health people. Same thing if someone just had a hip replacement but they didn't really fully rehabilitate from that and their function is still limited, maybe they really do need to go back to physical therapy. So really the first thing I think is listening. The second thing is I tell my patients, you are the boss. You are the boss. It's your body, and you get to decide what goes into it, what gets done to it. My job is to show you the whole landscape of what is available to you, and then you tell me what feels right for you. So I do talk to all my patients about diet, exercise, lifestyle modifications, but also if they are candidates for anti-obesity medication, about that, or candidates for bariatric surgery, about that. And even if they're new to me, I don't take anything off the table. I tell them it's my job to put everything on the table, and then they hear and they tell me what feels right for you. And so I really think it's mostly about, listening and then educating and reminding again patients that this is a long-term relationship. This is not something that's going to end tomorrow. And if we try something and it doesn't end up feeling right for that person, or it's not working for that person, let's just stay nimble and flexible, and we can sort of just change directions as we need to, because that's life, right?
Yeah, Leigh, I agree 100% with you. I practice the same way. I lay out the continuum of care early on. And in part, I'm doing everything you just said. We have all these things, you're the boss, and so on. And I also do it to basically saying, I've got your back. If one thing doesn't work, I don't want you to walk away saying, I have failed, like they would say themselves. Rather, we need other options. So I lay that out in the beginning, and then I say, of what I said, what makes sense to you? So I think I'm saying the exact same thing you do, and we are actually totally aligned in how we talk
Well,
about
I
this.
know you are a master clinician, Bob, so that does not surprise me.
Leigh, let me turn to the clinician. You talked about pathway, which lays out as a framework and it facilitates care. But I think a lot of clinicians were not trained well enough in whether it's nurse practitioner, physician associate, or physician. I would say insufficient training in obesity. So, what do you tell clinicians who want to do a better job with their patients but don't feel confident or competent enough with the knowledge and the attitudes and the skills?
Well, I don't think there's anyone that knows more about that than you do. Because you've been trying to educate clinicians around this for so many years. But I will say, I think the first place is just to let all the clinicians out there know that what we've learned about obesity as a disease has exploded in the last decade or so. And so what we may have been taught about it was probably not right. And it's time to get back in there and get educated about what we know now. And it's really, really different. And knowing that you're not going to have just a frustrating conversation that ends with no real treatments for patients that work is really changed. I mean, we really now have treatments that actually work. And not only do they actually work, but they actually have outcomes data showing that they prevent heart disease, heart failure, progression of chronic kidney disease. I mean, things that are the ultimate endpoints that we're trying to prevent in many of our patients with obesity. And so many of our colleagues are very risk averse. And so I think it's very comforting to know that many of these new medications are being tested or have been tested for long-term safety. So I think that's a huge relief. And I think that, coverage is getting better for that. And also just reminding ourselves the primordial reason that we are in medicine. It is to take care of our patients and prevent all these terrible diseases. Medicine's been so reactionary. We're so good at treating diabetes and sleep apnea and hypertension, but nobody wants all those problems and nobody wants the 64 medications that come to treat all that. And so if you can really, reverse that, you give your patient their life back. You actually reverse their clock. They're 20 years younger suddenly, and they're looking at you and they're ready to make really different decisions moving forward. And they'll hug you, whisper in your ear, I can't live without you. And we remember why we went into medicine in the first place. I mean, it is really the beautiful, most, like I'd say, primal reason that most of us are here.
Well, if you want a hug, first of all, listen to you, I think, and do what you say or recommend when you see patients. Certainly, if clinicians want to learn more, they can. There's so many things online now with virtual learning, inpatient learning. I mean, in-person learning. You can go to an obesity conference. I would say almost every society now has a satellite symposium or a session on obesity. As you said, it's involving so many organ systems now. So I would say open your ears, listen, and be proactive to learn about obesity. It's almost everywhere now.
Yeah. And Bob, you've been a real champion about getting, training for obesity as a requirement and, medical education for students and for house staff and being part of, board exams and really making sure that people learn it, know it, and then get tested on it. And so truly, like, bravo to you. My hat's off to you. I mean,
Thank you.
I think that is, making it the education more required, which I think it
Right.
should.
Well, we're trying to change education during training years for sure. But a lot of the listeners to this podcast, of course, are already in practice. So moving forward, there really are a lot of opportunities. I want to stick with treatment because that's where you're taking me, and that's exactly where I wanted to go. One thing I always say is that obesity care is a team sport. You don't have to go it alone. And I wonder if you can talk a little bit about interprofessional care and support teams when we're treating obesity in the clinic.
So I think this is kind of a little bit what I was alluding to earlier. Like, as you're listening to your patient talk, if they're really telling you that they have a lot of trauma in the past, and that has been maybe a reason that they are where they are and they've not been able to get to where they want to be, and you are not trained to work through trauma with a patient, which I can say I am not, that is where I will enlist behavioral health or mental health or somebody like this. If someone's telling you they're having functional limitations or pain, functional limitations to me is a time that you get physical therapy or occupational therapy involved. Chronic pain from something, anything, really maybe need a pain specialist to be part of your team. I think that all roads, whether you do bariatric surgery or anti-obesity medications, do lead to, better diet, less intake of food, more activity and things like that. So if you have dietitians that you can get involved, I think that's a real strength as well. For patients that are open to bariatric surgery, who you believe are good candidates for that, getting in touch with your bariatric colleagues. There's an increasing number of endoscopic procedures now. And so I really think, using the full breadth of the team and really just putting it out there for patients to make those choices around what they think would be good for them.
Yeah, I agree. I agree completely. Those of us who are doing this more than at least outside of primary care have these resources available to us. A lot of primary care, unless it's embedded in a program, which is not terribly common, you really need to develop those referral pathways and make sure you're on the same page. You don't want to refer someone, let's say, to a psychologist or a dietitian to give examples, where they are doing therapy that is not at all what you are recommending. You have to be in sync as far as that team's concerned.
Amen to that. I have referred patients to dietitians that are still doing the food pyramid. I'm like, oh, I thought that thing died like 20 years ago. So I completely agree.
Let's turn to medication. You brought that up earlier, and you are clearly an advocate for it, and you get a hug for it and everything. But from the patient's point of view, not all patients are coming in being huggers. Some of them come in, I'm sure, with concerns. Something like either it's for an influencer, social media, or a good friend or family member. They have done well. They've saw the individual lose weight. They may be coming in asking, "Am I a candidate for medication?" But what are the common questions or concerns or hesitancies that patients may have about medication, and how should we respond to those questions or concerns?
Yeah, I mean, I think probably the most common place that people get their information is online, right? And there's so much misinformation and disinformation about medications. And so I think the first place I start is, does this person have an indication for anti-obesity medication? Meaning, do they have a BMI of 30 or greater or 27 with comorbidities? Second, do they have a contraindication to a certain medication? Because if they have heart disease, I'm not going to talk about certain medications. If they have medullary thyroid cancer, I'm not going to talk about certain medications. So listening to the contraindications. Then if they're telling me that really they don't tolerate, their stomach's upset all the time, it might lead me to one medication versus another because I know that certain medications have certain side effects. And that person's already telling you that they barely tolerate this, then that may not be the best medication for them. And then after that, I just explain that they have an indication for medication. They don't have contraindications based on what they've told me. These certain medications may be good for them. It's sort of outlining what that looks like for them, the common side effects. And then again, reminding them that whatever we do, it really does need to be long-term. But again, that if we try something and it ends up not being a good fit for them, that we could switch gears.
Yeah, I think the last thing you said to me, and I'm interested in in what your thoughts are. That last thing about long term, that's so common. Do I need to be on it for the rest of my life? Can I get off it? How long do I need to take it? I need a quick fix. It comes out in many ways. How do you respond to that?
I said, whatever we do needs to be long term. And if you think about any disease state, whether it's hypertension, dyslipidemia, diabetes, asthma, I mean, MS, anything that you do, if you initiate a treatment, it might treat that disease. And if you withdraw it, then that disease can flare, or blood pressure comes up, or lipids come up, or A1C comes up. That's not a surprise anywhere in medicine. And yet somehow people still think that you can initiate an anti-obesity medication, achieve your goals, and then withdraw it. It's not that way. It's the same as any other disease state. So just really being very clear that that's what that looks like with patients.
Yeah, agree. So Leigh, we're coming to the end of the podcast, and I want to leave our listeners with you answering this question. So you looking forward, what changes or innovations do you hope to see in the management of obesity that would further support patient preferences or improve shared decision making? That's a big word that you really you embed that, I think, empower. You live that whole idea of shared decision making.
Yeah, I mean, I think that's how you're effective in really helping patients. And I mean, I say, better therapies, safer therapies, therapies with less side effects, therapies with better coverage, therapies that could potentially reset set point. I mean, can you even imagine, Bob? I mean, reducing someone's body weight to their dream body weight. And once you keep them there for long enough that their body actually starts getting used to that, and then maybe they don't need the medicine for the rest of their life. So I think the frontiers for obesity care are many, but I think our progress towards them has been tremendous.
Yeah, I agree. The medications have exploded, as you've said before. Just to reiterate, that exploded this area. I mean, never before in my career have patients, come into this in Chicago, come into the city or pay for childcare, pay for parking, walk to the clinic, and do everything in their life to talk about medication. That's never happened before. So it's really empowered and excited patients and clinicians alike in the field of obesity.
Totally agree. It's been amazing to watch.
So, Leigh, this has been delightful. Your insights have been very helpful and sharing your experience. Good luck with the pathway. I know you're going to let people know about that, and hopefully they can use that within their own systems once you get some outcomes from that.
Yeah, we hope to publish our outcomes next June.
Wonderful. Well, thank you very much, Leigh, and I hope all listeners have enjoyed this and have a little bit more insight on how to provide obesity care within their clinic. Thank you.
Thank you.